I'm delighted to be here to present the work that we're doing at the University of Queensland in Brisbane, Australia. And as you will see, I'm the director of the Recover Injury Research Centre. I'm a speech pathologist by profession, but I'm also the co-director of the Centre for Research in Telerehabilitation, along with my colleague, Professor Trevor Russell, who you will hear from tomorrow. Trevor and I have engaged in telerehabilitation research now since 2002 and have done a lot of the preliminary work in the validation of applications in telerehabilitation in speech pathology and physiotherapy. So today I'm going to talk to you about speech pathology management of motor speech disorders via telerehabilitation. And I'd like to acknowledge all of the researchers in the Centre for Research in Telerehabilitation, including Dr. Annie Hill, who is here today, and she will be presenting as well on the work that she has done. Okay, so today I'm going to talk just quickly about the management of motor speech disorders from the perspective of speech pathologists, the benefits and challenges of telerehabilitation, and then go through some of the research evidence that relates to telerehab and motor speech disorders, and then just briefly a bit about where I see we should go from here. So motor speech disorders, there are two main types of motor speech disorders. One is dysarthria, which is a disturbance in the muscular control of components of the speech mechanism. And these are components such as respiration, phonation, resonance, and articulation. So disturbance, neurological disturbance of the muscular control. The other type of motor speech disorder that's probably less common is apraxia of speech, and that's basically an impairment of programming of the articulatory movements. And people with apraxia of speech have deficits in the positioning, sequencing, and timing of articulatory movements. So in the management of motor speech disorders by speech pathologists, we look at assessing each component of the speech mechanism and the person's quality of life in dealing with a communication disorder such as this. We look at retraining of the speech motor control in these patients, and also we look at speech maintenance because these do inevitably become chronic conditions. Our treatment is very much centred on the principles of motor learning and the principles of experience-dependent neuroplasticity. And that means that we follow the principles of use it or lose it. They must speak, otherwise they will lose their speech. Use it to improve it. Intensity matters. Intensity is very important, and repetition is very important. And we've heard other speakers this morning talk about the importance of repetition and intensity. So what are the benefits of telerehabilitation for people with motor speech disorders? Telerehabilitation allows us to support these principles of motor learning and experience-dependent neuroplasticity. It allows us to have easier access, the patients have easier access to intensive treatment and to opportunities for repeated speech practice. It also allows real-world intervention. So it facilitates speech rehabilitation in a natural setting, and particularly where we are seeing people in the home. And that's very important for them that the types of strategies we're teaching them allow them to improve their functional communication. It also improves the quality of the intervention. It allows us to improve the timing of the intervention and intervene in a timely manner and be more flexible about how we conduct these interventions, particularly pertinent for people who have progressive dysarthria, such as those patients with Parkinson's disease. So being able to intervene with those people, give them intensive treatment to help them maintain their speech. It also helps us, telerehabilitation also helps us with respect to the sequencing of the intervention. Allows us to do things like intensive treatment, then a maintenance period where they can be monitored. We might then decide that the patient needs to have another short-term period of treatment, and we go back into a monitoring phase. So all of that can be done now via technology and through telerehabilitation. So it does support all of these principles of intervention that we as speech pathologists adhere to. But what are the challenges of telerehabilitation for this group of patients? One of the most challenging aspect, I think, in working with patients with motor speech disorders is determining the functionality of your technology. So to be able to deliver the types of speech treatments that we want to deliver, we need to have the technology that will allow us to do the various activities and tasks in that intervention. So clearly we need audio and video functionality. We definitely need to have some real-time intervention. We need to have maintenance of fairly high-quality audio and video too. So they're the two essential components. We need to consider the stimuli that we're using and how we present those to the patients and the types of exercises, etc., that we want them to do. We also need to consider how the client's going to respond to us in what is the activity we want them to do. And the other important aspect is the availability of objective measurement of some of the speech parameters. And that's a tricky one, which I'll come back to. The other important challenge is availability of standardised assessments online. Right now, in English-speaking world, we have to get permission from the publishers of the standardised assessments to reproduce these in the online environment. So that creates a barrier to being able to do some of the standardised assessments online. So these are some of the challenges. So when we're assessing people with motor speech disorders, we have a whole range of assessments which might involve informal assessments, an oromotor assessment, for example. We do perceptual ratings of people's speech. There are standardised assessments that we use, and as I said, these are the ones that we need to get permission for. And we need to do, in some cases, objective measurement of speech, for example, with Parkinson's patients, where we want to measure the volume of the speech and the frequency of the speech. So we also then use quality of life measures, where we ask the patient and their carers to provide some feedback to us about how well they feel their speech is going and whether it's improving or not. So when we look at considering the technology that we need in assessment, for oromotor assessment, this is just an example. We need video conferencing. We need close-up visual, so we can look at the in an oromotor assessment. We need very good audio quality for laryngeal subsystems. So for us to be able to assess the patient's phonation or their voice, we need to have good audio quality for that. We need capacity to audio and video record the patient in real time, so we can take that data away and do our perceptual ratings on that data. Soft palate function is one of the very tricky areas because you can't really visualise that online unless you have some external peripheral camera and a light source attached to that. So that you then rely on your perceptual judgment of soft palate function. And of course, we need to be able to upload written material, images or text to the patient's computer. So we can rate severity online, speech characteristics. When it comes to objective measures, we need some dedicated software for that or recording devices on the patient's end to be able to measure that. Then when it comes to the quality of life assessments, many of these are rating scales which can be sent to the patient via email if need be, or they can be displayed online and the patient can score or rate those as they go. So when it comes to the treatment, much of the treatment that we do nowadays in relation to these conditions is intensive treatment protocols. And these may involve therapy that targets each of the speech subsystems, respiration, phonation, resonance, articulation, etc. or they are specific intensive treatment protocols, such as Lsvt Loud, that is used in Parkinson's disease, and another one that we're developing at the University of Queensland called Be Clear. These treatments involve 1 hour a day, 4 days a week for 4 weeks. So the intensity of that obviously has implications for people in having access. They involve a variety of stimuli, images, written text, verbal and video stimuli. They require auditory feedback to the client for them to self-monitor their speech. So we need to be able to record the speech online, and we need to be able to play that back to the patient so that they can listen to their speech and self-monitor. And then, of course, we have the issue of objective measurement of sound pressure level and pitch online as well. So what we tend to do now in our work and certainly with our students at the University of Queensland is to go through a process of a task analysis where we take, if it's a treatment or assessment, we go through and look at what are the tasks, what's the type of interaction we want, what are the stimuli that we need, and the client response, and then what's the technical function that you need to execute that session. And when you break it down in that way, you get to have a better feel for the type of technology that you need to execute that particular treatment session. So that's just an example of the Be Clear treatment online that we're doing, and it takes you through each of the phases of the treatment and the type of technology that you need. And I think this is one of the big challenges for us in the speech pathology area, is making sure that the technology will do what we need to be able to do the treatment, okay? So it's an important aspect. So just a bit about some of the research evidence that's out there about telerehabilitation and the management of motor speech disorders. So today I'll talk about progressive dysarthria, and particularly Parkinson's disease, a bit about the non-progressive dysarthrias, and then you'll see a very distinct gap in the area of apraxia of speech. So we have done some considerable work over the years in the area of Parkinson's disease, and we have looked at validating the assessment online in Parkinson's. And this was a study done way back in 2010, where we took 61 people with Parkinson and assessed them simultaneously online and face-to-face. And this was done in a laboratory setting. And we did this with real-time video conferencing back then at 128 kilobits per second, right? So this was really low speed. And we did perceptual and acoustic evaluation of these patients. Now, with respect to the objective measurements, what we did here is we had a dedicated acoustic speech processor that allowed us to measure SPL and pitch online, right? And this took quite a lot of work with our engineering department to make this happen, but we were able to achieve that in this very, very prototype version. But essentially what we found with this study was that we could get comparable levels of agreement in assessment between the online and face-to-face therapists. So we felt that was well and truly validated the assessment online. We then took the study to a treatment study, and this was once again laboratory-based from room to room. And this were 34 people with Parkinson's with a mild to moderate dysarthria, and they were randomised to online or face-to-face and were given the Lsvt Loud treatment. And once again done real-time video conferencing at 128 kilobits per second. And similar assessments that we had done in the previous study, and this was a non-inferiority randomised controlled trial. So we saw significant improvements on the majority of measures noted following online and online Lsvt, and there was no significant differences between the two groups with respect to the level of improvement. So what we concluded that online Lsvt was clinically valid and reliable using this technology. Now that involved that acoustic processing system that we had developed. Okay, we then took the study to the home, and so that these patients were seen in their home using the technology platform that we have at the University of Queensland called EHAB, and I'll tell you a bit about that in a minute. Once again, a non-inferiority RCT. We had 52 participants, and we had two groups, one in the metropolitan area who were treated face-to-face, one in the metropolitan area who were treated online, and then we had people living outside the metropolitan area who we treated online as well. So what we found that, once again, that the groups, the online and face-to-face groups, were comparable improvements and outcomes when treated with LSVT. So whether you were online or face-to-face, it was very, very similar. So we felt that that study had demonstrated for us that we could take this into the home. Now, the system that we use is EHAB, which was developed by Professor Trevor Russell, and this system is completely controlled remotely by the clinician, real-time video conferencing, and has single and now has multi-point video conferencing. It has store and forward features, so things are recorded at the patient end, forwarded to the clinician. It's multimedia. We can provide images, written material, records. It records and plays back audio and video files. And inbuilt within this particular iteration of EHAB, it's since gone to other iterations, was an acoustic measurement software that allowed us then to measure sound pressure level and the frequency of the voice. Now, interestingly, very recently, there's been a study by Griffin et al. In 2017, which looked at trying to use LSVT loud via the iPad. Okay? Now, this study certainly was something that needed to be done to see if you could deliver this using an iPad, which many, many people have nowadays. And they had 8 participants with Parkinson's disease, and they did this through FaceTime using that process. The problem here, of course, was that they did not have the software to be able to make the measurements at the patient's end for sound pressure level and pitch. And they positioned a sound pressure level at the patient's end and positioned it in a way that the clinician could see and read the levels off from that. The problem with that, of course, is that any delays, etc., in the internet, you are not going to get exact measurement. So, however, they found that for some aspects of it, it was not inferior to historical data of treatment with LSVT loud, but really they found that the technology, they needed to address the technology, and once again, this was the downfall of the iPad because it did not have that inbuilt software to measure those critical parameters that we need when we do LSVT loud. But they feel it has potential and needs some further development of the system. So I think this highlights one of the big challenges of tele-rehab in this particular field, where those objective measurements, it's very difficult to do them without dedicated type software. So back at the University of Queensland, have done a small feasibility study of looking at group therapy for people with Parkinson's disease. And these will be people who have gone through LSVT loud, and then we decided to do a group therapy as a maintenance program for people with Parkinson's. And this was 90 minutes twice a week for 4 weeks. So once again, the intensity concept comes in. And at the time we did this study, we used Adobe Connect that was available for us at the University of Queensland. And it was okay, but a little clunky. We just opted to use that at that particular time. So it was hardwired or Wi-Fi connection in the home, Logitech web cameras or inbuilt cameras in their computers, Software was installed on the participant's computer by the speech pathologist, and the participants were provided with a technology setup instruction booklet, etc., to do this. So in this particular group therapy, we wanted to deliver this therapy, of course, in real time. We wanted to capture some high-quality audio and video recordings of the participants. We needed to present treatment materials to all the participants. And we also needed to move pairs of participants into breakout rooms to practice their reading and conversation tasks. So Adobe Connect allows you to do that, to take people and move them out into a separate room, which our EHAB system couldn't do at that particular point in time. So we also played simulated background noise as well. So this program, and I'm going to flick through this quickly, what we assessed them pre-post in 3 months, and we found that significant improvements in their sound pressure level over that period of time, and we found that group therapy was feasible, but we need to do, obviously, more clinical trials. And we need more user-friendly technology to be able to make that work. Another one, of course, many of you will be familiar with, perhaps in speech pathology, is Lsvt Companion. That was a computer-based software for practice for people with Parkinson's disease. So when we look at non-progressive dysarthria, a study we did, Annie did the very first study about validating assessment of people with dysarthria who are from stroke or TBI. And we found in this one, of course, that online assessment was valid and reliable for dysarthria via internet. We're now looking at treatment of people with non-progressive dysarthria online, and this is a very small study we've done with 7 people, and it's ongoing. We're still collecting data. And this is with the Be Clear program, which is an intensive treatment for non-progressive dysarthria. And the patients go through an intensive 1 hour a day, 4 days a week for 4 weeks. And we assess them baseline, post, and at 3 months. So what we found with these patients is that we see a lessening of the dysarthria impact, and this is the impact of dysarthria on their life. The majority of people found there was less impact. Their communication effectiveness improved for the majority of people. The carers noted an improvement in their speech as well, and their communication participation in the real world also improved for many of these people. We see very high satisfaction in all of these studies for people with telerehabilitation, often 100%, 90 to 100% on all of these studies, and people really see functional improvements as a result. So we see that this study is, we're progressing this study and hoping that this will develop well as an online treatment. This is a study that comes out of the UK just recently on a web-based software program called Ready Speech that they're developing to allow people to do asynchronous therapy, so to practice on their own at home. So that one's still under development, so one to watch, I think, and it is accessible on any Wi-Fi device, and there's a range of activities that are uploaded to this system for people to do. So they have had some success with this one, but need a lot more feasibility trials, so certainly something to look at. This is another web-based application for speech training coming out of the Netherlands, but this is undergoing further development. So there are lots of things happening in the space. Apraxia of speech, really we have not done much in this area, and there's not much reported. This is the first validation study of assessment that Anne Hill did, and we found that to be reasonably feasible to do this online. So, in conclusion, where to from here in this space? We need, obviously, to establish the efficacy in larger clinical trials. We need to increase the availability of online assessment tools. One of the things that would be really great is to have speech recognition software that would give us an objective measurement of speech and intelligibility. We need acoustic speech measurement, and we need more informal and standardised assessment tools. We need to develop more the asynchronous software and mobile applications that'll facilitate client self-management, clinician monitoring of speech maintenance. But ultimately, I feel where we need to go with this area is to develop an integrated online platform that incorporates all of that: real-time video conferencing, online assessment tools, asynchronous software, and remote monitoring by clinician, and also has capacity to train clinicians in how to deliver this therapy. Thank you.
Thank you, Professor Theodoros. There is time for a few questions. I'll start with, well, really inspiring talk. And I just wonder about the cost of tools in order to implement this in healthcare system.
The cost of implementing it. I guess, you know, that's going to vary across all of the countries that are here. In Australia, we have a large public health system where much of this will be implemented into the public health system. So in Australia, you can go to any public hospital and receive a service. So that's where mostly where this will become implemented. We also have private health insurance, so if you are covered by private health insurance, you could pay to have this through a private speech pathologist. We just completed a study on cost analysis in the Parkinson one, and what that is showing, of course, is there's significant savings for people who do the treatment online, but that data is about to come out. But yes, mostly in the public health system, that people will be implementing that. But we need more studies on implementation into the health service and all the components that surround that, and including the cost and the time that's taken as well. One of the big barriers that is reported mostly in telerehabilitation, and I think this covers any discipline, is that it's not the patient who is the barrier, but the clinician, right? Because the clinicians are either fearful of the technology, see this as something new, see that it's going to take time to be able to implement, and because they need the training and expertise in being able to deliver via Tele. So we find that in almost every study, and you'll see that in the literature, it always seems to be clinician as opposed to the patient. Yeah. Thank you. Is that it? Any more questions?
More question? Further down, maybe we need a microphone there.
Well, compliments. I mean, this is these are really nice programs, actually. And my question is actually because we keep developing systems, we keep developing programs within various projects.
Mm-hmm.
What is the availability of your systems to others?
Yes, it's a very good question, because that's true. In every country, we tend to develop our own thing, and then, you know, it's not available in other countries. The EHAB system has been used and is being used in US, obviously in Australia, but mostly for research projects, right? We have to look at the FDA approvals to go into various countries, and that requires a considerable amount of money to get those kinds of things to come on board. There is a general tendency now for the tightening around all of this to reduce somewhat, so that can happen. Trevor might want to comment a little further about that, but yes, certainly that is an issue for all of us. So it's kind of like we're all reinventing the wheel in many ways, and which is sort of not logical, in many ways. So I totally agree with you on that. But I'm not sure how we move beyond that. If you've got an idea, that would be great. Do you have one? No? Okay.
Thank you very much.
Mm-hmm.